next session, a panel discussion on acute pancreatitis. I invite Dr. T.D. Hadar as moderator. Dr. T.D. Hadar is a professor in the Department of Surgical Gastroenterology and Liver Transplantation at PGI Chandigarh. I also invite the panelists, Dr. Rajendra Desai, professor and senior consultant in GI and HPB surgery, unit chief at IIN Institute of Medical Science, Hyderabad. Dr. Rajesh Panwar, Associate Professor of GI Surgery and Liver Transplantation, AIMS Delhi, and also Dr. Sadaf Ali, Professor and Head of Department of Surgical Gastroenterology, Sher Kashmir Institute of Medical Science, Srinagar.
Very good morning, and once again, like we said, everybody is thanking sir. We started this meticulous program every year, and every time we get benefited by preparing the talk and listening to others. And I welcome my panelists, Dr. Sadaf, Dr. Desai, and Dr. Rajesh. So, what I have done, gone a little bit again what sir said, because acute pancreatitis is very, it will be very short if I just talk about some complications after the surgery. So I have, from the regional point of view, I've just tried to make few, 3, 4 slide basics, then try to discuss a little bit early part of the management, then going to the complications. So all the protocols have been already sent to all people by Dr. Kapoor. So everything has been done. So there has been an extensive advancement in the management of acute pancreatitis. So nowadays, as a surgeon, we are seeing so less number of pancreatitis because everything is being taken care of by the intensivist and gastroenterologist and ICU competent persons. And surgical people are called only when there is a problem, like, and then endoscopic management of the pancreatic necrosis. Earlier it was not there, so we were called earlier. Nowadays we are at the corner, but we are part of the team. So it is a multidisciplinary approach where it is required, and because of the evolution in the nutrition management, intensivist and antibiotic coming up, evolution, all these things have taken to the decrease in the mortality. So when I was registered, I used to say when patient requires surgery, hardly used to see any patient going home. So time has changed a lot. So if you see what is the clinical course, hardly 20% of the patient they will require any surgical intervention. And as I said, that has multiple components now. And out of that 20%, if they require surgery, then after the surgery, local complications and complications during surgery or complications because of the multi-organ system failure, because of the sepsis, the mortality of the all is very, very high. And today, even if you see the mortality rate, overall mortality is still about close to 18 to 20% in the best centers in patient requiring surgery. So management principle, as we say, it is a bimodal disease process because in the beginning, all the problems are because of the extensive inflammatory mediators. So people are going into multi-organ system failure, coming with organ failure. But later on, the sepsis component takes part. So that's why delaying surgery is the basic management principle nowadays. So the presentation, as I said, is because of the early mods and late mods. And early mods is because of the inflammatory mediators, and late mods is because of the setting of the sepsis. So these are the things one should know. So rationale is why we are talking about delayed surgery. So if you see all the pictures here and same patient, according to the change of the time, there is more localization of the inflammation. Wall is nicely made. So if you are going late, the treatment also will be localized, and you can do the tissue so the less hemorrhage and well defined tissue, and then you can take the tissue out only necrosum, not the pancreas, and that has led to the decrease in the mortality. So this is my basics. Then I go to my first panelist, Dr. Sadaf. Dr. Sadaf, we are talking too much about fluid resuscitation. So such an important component of pancreatitis management. So initially it was that give lots of fluid because of the vasodilatation and lots of fluid is shifted inside my extravascular compartment. So nowadays there has been, it seems a little bit a paradigm shift. So can you please give your comment on the what fluid should be given, how fluid should be resuscitation should be done? in the patient have acute severe pancreatitis. We are talking only about severe pancreatitis. We are not keeping aside the mild pancreatitis.
See, if it is not for mild acute pancreatitis, where initially people used to think that there is over restricting and not letting you slip into from mild acute to severe acute, then in all cases of moderate acute and especially in severe acute pancreatitis, there's a lot of capillary seepage in third space of fluid. If you don't give a goal directed fluid therapy, then the patient is likely to have pulmonary edema. It is likely the patient is likely to have AKI and many other complications. Then the organ failure creeps in and so many things happen. So it's very important that there's also that waterfall trial which was subsequently stopped as they wanted to give an aggressive versus a not so aggressive fluid therapy. Initial resuscitation few hours they were thinking of giving 200 ml versus 300 ml, and then the maintenance was 1.5 versus 3 ml per kg per hour. So then more appropriate is till when you streamline the hemodynamics. It's all important that you assess in what condition your patient's fluid and electrolyte situation is when you are taking the patient. What is the respiratory status? How he has been treated by the previous center? And a goal-directed fluid therapy of initial few hours till your hypotension is corrected, and then reassess, put in a central venous catheter, see the pressures, and accordingly you should give fluid to these patients. And the type of fluid is also very important. Like the concept of normal saline is no more, because there are many comparative studies which have shown that lactated ringer solution, what we call as RL, is having better, decrease in the inflammatory markers like CRP.
Yes.
And other cells, which again helps in the recovery of or controlling the SIRS. So the type of fluid and the amount of fluid are very important. It should be goal directed.
So if I can summarize that the concept of pancreatic ischemia, which leads to the damage. So in the beginning, we have to try to control the pancreatic ischemia by resuscitation. And the first 6 hours, you can give the fluids maybe little bit more, but after that, you have to go to the 1 to 1.5 ml per kg body weight per hour, and the fluid is required. Usually, and there is, as you said, there is a RCT between the lung ringer lactate and the normal saline. Normal saline is almost isotonic saline. Ringer lactate is little bit hypotonic, but it has been found that ringer lactate is the best solution, and there is no scope for the colloidal solutions in the resuscitation. So, to agree, if I summarize that,
Yeah.
So second important issue in the management of pancreatitis is antibiotics. So, Dr. Rajendra Desai, can you go give some thoughts about the starting antibiotic?
Yeah, I'd like to trace the evolution of the use of antibiotics. We started with a phase where we started it in all patients of pancreatitis. Then it came down to treating only severe acute pancreatitis with complications. And now it is goal-directed antibiotic therapy. So basically, when you choose an antibiotic, it should penetrate the pancreatic necrotic fluid and the pancreas. So mostly the agents that are used are meropenem and etrapenem at the moment, because they are broad spectrum. They cover aerobic negative organisms, gram-negative organisms, and they also penetrate the pancreatic tissue. About antibiotics being goal derived, it has been shown that unless there is infection in the pancreatic necrosis, there is no indication for antibiotics. And nowadays, antibiotics have assumed a role in the treatment of infective pancreatic necrosis, that in many patients, you are able to avoid surgery while treating with antibiotics, even in the presence of necrotic tissue. The third thing is, when you give antibiotics, the beneficial effect that has been seen has been that there is a reduction in overall incidence of infection, but no reduction in infective pancreatic necrosis. So pulmonary, GI, and renal infections are reduced when you give antibiotic early. But this is balanced out by an increased incidence of fungal infections in patients with acute pancreatic necrosis, where antibiotics are used excessively. So briefly, I would say that it has to be goal-directed antibiotic therapy only in infective necrosis, and this is imaging evidence of infective necrosis.
So if I summarize by saying that prophylactic antibiotics used to be the starting point, when patient is coming in acute severe pancreatitis, it should not be used. And there are multiple trials. Before 2006, there were some trials where some benefit there is a calculated also. After starting early antibiotics were found, but as Dr. Rajendra has said, that nowadays, if there is no suggestion of infection anywhere in the pancreas, you have to rule out other organs. So why there is a problem like where patient is going to search. So if there is no documented source of the infection, the antibiotics has been not found to be of any use. And infected pancreatic, as I said, you can see the references and you can go and read this, that infected pancreatic necrosis is not synonymous that you start. But the practical point is most of the patients when they come to us, they have been already started with the highest antibiotics. So that is the biggest issue we are seeing. So to summarize, that prophylactic antibiotics to prevent pancreatic infection is not recommended at this particular time. Tomorrow we don't know. So there is a level 3 evidence about that. So recommendation is when there is infection and then there should be antibiotics, and choice as Dr. Desai said, antibiotics should be concentrating in the pancreas. So like aminoglycoside, they don't concentrate, but some of them are very broad spectrum. So not only broad spectrum. So you try to cover about fungus. So prophylactic fungal, antifungal.
It's been shown that if you use prophylactic antifungal, you again end up with the resistant fungal organisms. Most infections nowadays are because of Candida gallipirata, which is not responsive to fluconazole. Only fluconazole has been shown to show some help in infected pancreatic necrosis if it's used. But infective antifungal agents like caspofungin and anidardorflungin are now required when they're based on a culture report of fungal growth. Only in those patients you are supposed to treat them with antifungals.
So when you are doing necrosectomy, you can send the tissue for the even staining also, because culture takes time. And if there are everything is going on, lots of antibiotic has been given, and suddenly patient goes into sepsis after necrosectomy, then probably you might think of starting antibiotic, but with a caveat. So again, prophylactic antifungal has no role. So coming to third very important component, Rajesh. So what about nutrition? Because this is the neglected area in our so what about nutrition? How, when to start nutrition? What should be the rule? And is nasogastric as good as nasojejunal? We used to start nasojejunal in the beginning, TPN or parenteral. So please, in short, can you just summarize?
So, as acute pancreatitis is an inflammatory process, and it has been compared to the same systemic stress as burns. So, a patient with acute pancreatitis requires nutrition similar to a patient who has severe burns. So, obviously, this part is very, very important. The fear of giving oral nutrition in pancreatitis is that it may increase the inflammation in pancreas. It may stress the pancreas to release more enzymes, and that can further increase the complications. But this effect has not been found in the studies. So if the other problem is that these patients, you often have nausea and vomiting, and they have local complications, collections around the stomach. So there is sort of a functional gastric outlet obstruction. So they may not tolerate oral nutrition, and in those patients, you may supplement a parenteral nutrition if they're not able to tolerate oral or enteral nutrition. But if a patient is feeling like eating orally, the oral nutrition is as good as any other form. Only thing is that it has to be low fat, low residue diet. And if the patient is not able to tolerate oral, the next route would be the enteral nasogastric route. And multiple studies have shown that nasojejunal is no better than nasogastric route. So if you are able to give nasogastric feeds, that next choice. And it has been shown that if you are giving enteral nutrition, then it maintains the gut lining, and it maintains the gut barrier, and it may actually prevent translocation of bacteria, and it may reduce the infection complications. On the other hand, parenteral nutrition has been associated with infectious complications.
Related sepsis.
Yes.
And the only statement is, so you can see these are the landmark studies which have compared nutrition, nasogastric and nasojejunal. So nasogastric, if there is no lots of vomiting and compression, nasojejunal, nasogastric can be started. Nasojejunal only when there is a huge collection, acute collection, and there is a patient is not able to take, then you can go for nasojejunal. it's very clear that internal nutrition should be started as early as possible once patient is stabilized. Is it
Yes,
okay?
yes, yes.
So nutrition in acute pancreatitis from old paradigm to new evidence. And new evidence is that patient should be given, and there is no rule of rest the pancreas nowadays. So resting pancreas has no role, and the we say that get the gut going. So gut should, if it is working, it should be even distension in the abdomen. Only contraindication might be intra-abdominal hypertension, which might create some problem. Otherwise, there is a there is no rule of this thing. So all these three pillars of the mind management of the pancreatitis, resuscitation, antibiotic, and nutrition, which are in the beginning for the region point of view, we have taken care. And now we go to the case capsule. So Dr. Sadaf, here is the summary of the patient. Sudden onset, there is a lady, sudden onset severe pain, radiating to back, multiple episodes of vomiting, no fever, no jaundice. Managed conservatively in the beginning, and then there is a similar episode about 20 days back. So she was diagnosed as acute nephrizing pancreatitis. It was related to gallstone. There is a local complication in the patient. So you could see this. There is a local complication. However, there is no fever. There is no tachycardia. She is walking and about, up and about. Only the problem she had is postprandial fullness. So how would you approach this patient?
As this is just 3 weeks post acute pancreatitis. And I can see a big collection over there, which is subsequently likely to be a walled off necrosis. And as you said, that symptomatically her only concern is that she has more of vomiting due to sublocal compression. So this site of collection seems to be amenable to either to external drainage, or you can pull it for a week or so, and intragastric drainage can be another option. So endoscopic. So it you can make an assessment, see the bulge, and take a decision. There's no role of any open surgical treatment in this kind of walled off thing as of now in early phase of the disease. It doesn't look infected.
Just give two more points about timing of polycystectomy in this patient as well as other patient of gallstone pancreatitis.
See, as it seems that she doesn't have any organ failure and she is not a very severe kind of pancreatitis. So the timing of surgery for gallstone pancreatitis, as far as the Ponchu trial goes, it was mild to moderate. Then it can be operated in the same setting. But on the background of this kind of collection, you have to take a call about what you are going to do this about this collection, and it can be done earliest after in moderate acute pancreatitis after the complications of this kind of collection and all of the fluid, which might be of lesser complexity than this one, settles down, and then you can take it. And when it is severe acute and the patient's stay gets prolonged for months or years, then you understand that it gets delayed even beyond. So only mild acute pancreatitis you can do it in same setting. Other patients you have to take a call based on the local findings.
So if there is no necrosis, there is no severity, mild acute pancreatitis, if they are admitted in the same setting and operated polycystectomy, the complications in the future are much lesser, and the re-attack of the acute severe of the pancreatitis which might be severe. So this is very important message that gallstone pancreatitis should be managed, and patient like this can be managed on case and case basis. Like she has no symptom, but there is a collection. So for the collection, she is not able to take. You can go do PCT, and later on, maybe after 2 weeks, we can go for a okay. Thank you. So gallstone pancreatitis, as I said, we have already summarized, so we are not going there. So now, Dr. Desai, here is a patient, a resident, 4-5 days, whatever time within this CT scan is done, and this is the CT scan. So what message you will give to the resident?
Yeah, it's important to notice that this is a contrast enhanced CT scan, and there are increased densities inside the lucent area which is seen. This lucent area is probably a collection, the exact nature of which is very difficult to say because it's iso intense. But these hyperdensities inside the lesion suggest a hemorrhage or a recent hemorrhage into the cyst. And we should make special effort to look for pseudoaneurysm formation in these sort of patients. If we can identify a pseudoaneurysm, that should be called and no attempt should be made to operate on these patients in an emergency. Even percutaneous drainage would be contraindicated. And if you find a pseudoaneurysm in any of the territory, either in the celiac or the superior mesenteric territory, you should embolize it and only then proceed with treatment of the local complication.
So I think very important as a registrar, please be aware of the enhancement inside the collection. And if it is there, first treatment is go do a CT angio, and then go and if there is the commonest is I will show in the slides is the splenic artery, then followed by gastroduodenal. Whatever is there needs symbolization. No intervention at that particular junction of any kind should be done. So this is the patient where embolization and the transarterial. So that's why I say in the beginning, the acute pancreatitis is no more only surgeons this. You have to have everybody in the armamentarium. So it is very, very important. So Rajesh, this patient, you are managing this patient and the CT scan done after 15 days. Here is the picture.
So here's a collection behind.
Options, I will ask for the options. Are you going to do straight away surgery required because of the hair, or do some FNA culture, or you are going for PCD?
So there's a lot of air inside the collection, which suggests that there's infection. Either there's infection or either there's a bowel communication. Previously, this was an indication for straightaway surgery, but it's not anymore. Now you can manage it per percutaneous. A study from our institute has already shown that FNA and culture sensitivity antibiotics hardly makes any difference as patients, so that is not required. So I would say that you can manage these patients with PCD nowadays, and the step-up approach can be applied to this sort of patient as well.
Very important that the only gas in that collection is not a straightaway indication for the surgery. So if you put a picture, not only that you are getting something, the intra cavity pressure goes down, and that is the one of the reasons why patient improve even without surgery. Even there is lots of semi-solid material in the collection. Even then people improve. So this is another scenario, Rajesh, same type of patient. But here is the patient, you see minimum postprandial fillness, and there is nothing, no sepsis at all. So same like Dr. Sadaf. Here is the patient. How will you approach this?
So this is 1 week post pain. So this is still in the early part. So obviously you don't expect any localization at this part. And since the patient doesn't have any sepsis, so this is a patient who has to be managed conservatively. And then you have to see for over the next few weeks, this collection may actually spontaneously resolve in some time, and if it doesn't resolve in the 6 weeks, then obviously you have the option to go in at that time, but right now you manage the patient conservatively. And since there's no sepsis, there's no need for antibiotics, and oral nutrition, if the patient can tolerate, is good enough. But you can see here that there is a tube inside, so if the patient is not able to tolerate oral or NG feeds, then obviously you can put in a nasojejunal tube in this patient.
Because the nutrition was an optimum, only tube had been fed. So very nicely summarized. So you don't need to rush after the CT scan. The patient is the first priority. Patient should be seen what are the symptoms, and based on that. So to summarize this collection, the sterile necrosis doesn't require any treatment. Wait and watch policy, and based on the time also. So Dr. Sadaf, the contrary to this is 45-year females, idiopathic pancreatic necrosis, and CCT abdomen on day 20. And you could see that score. So now, how will you see?
This seems to be a very high score with lot of necrosum. If I am correct, there's a central, as he said in the previous patient, there's some hyperechoic area in the center of the necrosis. It is air-filled, and this would need a management. I don't think it will be amenable to a step-up approach. He has already, it has been 40 days, you said. So this patient, only 20 days. So you can go for a good CT angio, and if there is an aneurysm over there, you will have to embolize it, and plus you will have to drain it. Maybe you will have to serially upstage your catheter. Because this is extensive, or it might even require multiple catheter placement because it goes onto the right renal space right up the pelvis.
So there was no enrichment in this patient, and this patient, you meant to say that we go by the first step of approach, increase the size of the PCD, what we have did. And if patient doesn't improve, then only any type of minimum invasive surgery can be recommended. So this is what is the management ability. So there is a Desai. When you are doing necrosectomy and you have removed this type of cast of the pancreas, but suddenly you are seeing that patient is having coming back to the having extensive hemorrhage, patient is bleeding like anything.
Basically, this sort of situation is not uncommon in patients with. This sort of situation is not uncommon in patients with pancreatic necrosectomy. Especially when a younger surgeon is operating, one of the main precautions is don't break any connections between the anterior part and the posterior part of the abdominal wall, because most of these will be thrombosed vessels or patent vessels. So you have to be very gentle. You have to remove it with a sponge holder, no traction. Don't disrupt these bands because you could end up with a major bleed. Now, if you end up with a bleed despite anything, this is basically because the pressure has been released in the cavity. There is an erosion of the wall. There is a rupture of the wall, and there is rapid bleeding. The bleeding can be venous or arterial. If it is venous or arterial, the first step is to pack the cavity with gauze and try to arrest the bleeding. If it's an arterial bleed, what you need to do is after this, you need to wheel the patient out and get them to have an angioembolization of the vessel that is involved. Please don't try to take sutures through this tissue and try to catch the vessel, because sutures cut through and you will change a simple bleed into an emergent hypotensive massive blood loss. So don't try to suture, pack it well. If you have interventional facilities, do interventional radiology. If it's a venous aneurysm, you can put a wired mesh stent. If it's a arterial bleed, you can then do an embolization of the cavity, and you can put covered stents which prevent lateral disruption of the arterial wall. So that's what I would recommend.
Okay. So just let me summarize. I always say that in acute pancreatitis, the management is aggressive, but the surgery is gentle. So don't even, I even don't recommend a sponge holder. So you take the, just try to fracture if you are doing minimum invasive by the suction, very mild, or if you are using your hand by your finger, index finger and thumb, little bit of fracture, then suck it out. So water does disrupt the tissue. So digitoplasia is one of the important issues. Rather than pulling anything which you are pulling, then you are in danger. And the best thing is that you should pack, don't try to cook anything, do anything more. 90% time this bleeding stops, go and remove after 72 hours. So this is Rajesh. Are you able to see something? This is another complication.
This is a migrated human opposing lambs.
Yeah. So necrosectomy done by, yes.
So nowadays necrosectomy is done by endoscopy. So they like to place large stents, and these human opposing stents actually make the procedure very easier because their scope can go inside the stent and they can do directly necrosectomy. But these stents are initially they were associated with very high risk of complication. They were associated with hemorrhage because you are punching the stomach with a large stent. So these are associated with bleeding. Another problem is that these stents can migrate.
Migrate, yes.
So once they migrate, the stomach wall is closed off, and now they lie in the connection. So you will be called upon to send such patients. So the treatment depends on whether the stent has migrated only into the lesser sac, or is that transmigrated to the mesocolon or other parts, and it has come to the normal peritoneal cavity. Because if it is only in the lesser sac, then you can go transgastric, open up the same neck side, endoscopic side, and can retrieve through that opening, and you can do a necrosectomy, transgastric necrosectomy. But if it has migrated intraperitoneal, then it is a big problem now because it will lead to a gastric fissure. So
even sometimes in colon also.
Yeah.
So, yeah.
This is going to be a difficult problem, and then you have to individually treat those patients depending on whether you can suture the defective stomach. The suture may not hold. So it will be a difficult situation here. The only thing is that you have to put wide board drains so that if there is a leak, it is controlled leak rather than an intraperitoneal leak.
So every advancement has its own accuracy. and we have to know that. So this is another patient, Rajesh, you see this 25 years male and blood in the bag after the necrosectomy. So necrosectomy was done. Suddenly one day after, on the rounds we were finding this type of hemorrhage.
So if there's hemorrhage, then obviously you straight away do CT angio. You are worried about is any pseudonism which can cause life-threatening hemorrhage. So that is what we need to rule out first. So here it's already it's showing pseudonism
Yeah.
in the splenic artery.
So patient is doing well. After 20 days also you can have this complication. And there is something called a cavity bead also. You do a CT angio, you don't find anything, but there is a granulation tissue starts bleeding. So there also the only treatment is go and pack it. Pack and pack. Many times packing might be required. So there was a patient who had a massive lower GI bleed after the necrosectomy. How will you proceed, Rajesh, in this?
Sir, in most of these instances, your necrosome has eroded into the colon, and so the bleed is actually may not be in the colon. Bleed may be again in the cavity, and that is tracking into the colon. So again, you have to do a CT angio to look for a pseudonism. And if you find that, then obviously you embolize that.
So you could see the younger people are sitting behind. You could see that this is not something where surgeon will go jump. Every time we are talking about CT angio, then you go and do a embolization. Surgeons are only required when everybody fails. So that is the good point and bad point both ways. So this is the patient where colonic massive GI bleed. Obviously, would like to resuscitate, stabilize, then probably try to do upper GI. But usually these people don't give so much of time. So CT angio probably first priority, and then stabilize, and this was the patient having colonic fistula and your student was bleeding inside this. So this is the bleeding complication. I have tried to whatever scenario we have seen cover, and but try to have a broad area to vision to everybody to understand. Then another very important complication is making up a fistula, GI fistula. So this is another problem which we face, and this are usually they are either they can be duodenal because of the necrosectomy, because duodenum is very close from any part of the duodenum, second, third, or it is colonic. Very rarely it can be gastric. So Dr. Sadaf, can you please?
If you have a colonic fistula, it doesn't become very complicated. And if you have a significant colonic fistula, patient becoming very sick, colonic fistula patient do become very sick, then you might have to give a diversion for the patient. And ileostomy would be a better option.
This thing procedure you cannot.
We have done it for quite some patient. I don't have much experience about duodenal fistula. They do fistulate and have internal issues, and accordingly you have to take care of the complication. Bile in the drain would be, I would say that it would need it would warrant an endoscopic ERCP if the patient is stable enough.
So usually if there is a feeding duodenectomy, nothing much is required. If there is no feeding duodenectomy, then you might need to have a nasojejunal or something for the nutrition. Colonic fistula usually as you said, feculent material in the drain, or there is a colonic necrosis also. So you said you can in a colonic fistula, a small colonic fistula, there is no necrosis, then you can go ahead. CT scan would be the first thing to do, and you can see whether colon is necrosed, if there is air around it. And if necrosis, I think epilectomy has to be done. Sometimes it's very difficult. So ileostomy is there is no gangrene. So this is the I think covers most of the complications which are seeing early complication. So this is our data summary of the GI bleed, and you could see that splenic artery is the one which is the biggest culprit to get involved by the pancreatitis. And at the time of surgery, because of the inflammatory mediators, wall gets weak, and then out of 3, you could see that the one died because of March 7 had pseudonuria, 4 DSA, 3 required surgery, and 1 rebleed, and 3 rebleed and died. So this is a very dreaded complication, and it needs lots of support care from other departments, and then very nice team which can recognize the complication at the earliest point of time, and we can do this appropriate treatment. So another important complication has been this. I am summarizing as this thing that post-operative complication has been GI hemorrhage. We have found this upper GI or lower GI, so intra-abdominal bleed or GI fistula. These are the
complications which are there. So we have to recognize this complication and take care, as we have discussed most of the things. So intra-abdominal abscess after the necrosectomy or recurrence of the necrosis is another, because in one go you cannot do everything. So if there is a patient is deteriorating, you are suspecting abscess, there should be low threshold to have a CT scan. And if CT scan suggests you do a percutaneous drainage or whatever is required. If there is a systemic sepsis, in spite of all antibiotics, then you can think about prophylactic antifungal, which sometimes we do it, or do some biochemical parameters which are available today to support your thinking. Wound infection and wound dehiscence after open is another important issue. So coming to post-operative, as I discussed, post-operative intracutaneous fistula, it can be gastric. As I said, gastric is the minimum, colonic is the maximum, and the small intestine very rarely. So these are the fistulae side, colon and duodenum, and it depends on the management, depends on the symptomatology of the patient. So as we have already discussed, and mortality, please remember, is very high when there is a fistula. So there could be a delayed complications, which can be exocrine insufficiency, endocrine insufficiency, complex pancreatic fistula, pseudocyst, and there is a pseudoaneurysm, and sometimes biliary stricture also. So these all is happening in acute pancreatitis. So there is a one of our patient with complex pancreatic fistula. We had to do a fistulojejunostomy. Pseudocyst can be there later on. Patient is gone home and coming back with the some issue, not in a related to sepsis. Then this patient might require some treatment based on the presentation. So I think I have tried to cover all these things. So in summary, about 7 minutes for the discussion, we can take the question. So I can summarize later on. So we can take the questions and then summarize. Any important points from the panelists more you want to add?
Sorry, before you take, for the sake of the young surgeons in the audience, can one of you please explain how to suspect that colon may, suppose you're doing a necrosectomy, how to suspect that colon may be involved, and if you have a doubt, what to do? Stoma, nothing, resection, what to be?
Yeah. The thing most important is when you are faced with a patient with sepsis, the patient presents to you as severe sepsis. You then do imaging to rule out pancreatic infection, necrotic infection. During that study, the radiologist will report to you whether there is evidence of colonic leak, whether there is any evidence of colonic necrosis, such as non-enhancement of the wall. If the colon is necrotic, we need to go for surgery. It needs to be a segmental excision and external derived stoma. The stoma depends on the location of the necrosis. So either an ileostomy or a colostomy, you bring it out as a loop and leave the other side closed and leave it inside. Because most often, because of abdominal swelling, you can't get the stomas up to the surface of the skin. So these difficulties are there, especially in obese populations. Ileostomy is drastically difficult to do, and you have a lot of post-colostomy, post-ileostomy retractions in these patients. So the simple question is, if there is necrosis, resect and exteriorize. If it's a floppy colon, you're not sure whether it's blocked, feel for the pulsations in the mesentery. If there are no pulsations in the mesentery or there are thick cord-like veins, you still excise the colon prophylactically and do an exteriorization. That's what would be my recommendation.
So I think, Rajendra, I could understand such question. Well, what is the
Intraoperative.
where is the necrosome? If it is on the left side, much more, which is usually there, and it is going behind the mesocolon, then when you are putting your incision and going behind the mesocolon, sometimes your finger gets stained of little bit of equivalent, but you are not saying anteriorly any type of colonic necrosis or something. In these patients, there may be small hole because of the necrosome or atrophy, because you are doing something, this wall is weak and this wall is little bit less vascularized. Then what you do? In this patient, put a drain there, always you are putting a drain, and important thing is do ileostomy. Here would be that patient. And second group, as Dr. Rajesh discussed, that patient may be colonic necrosis. And I agree that one time you could not, and remember also, if you are not able to remove, take the extract the colon, lots of blind segment is there. And if they are there in the abdomen, this patient is not going to have a good course in spite of the proximal diversion. So it is very, very important that if you are not able to take ileostomy loop, then it is important that you just do an end ileostomy. And ileostomy can be done with a little bit of mobility. Yes. So any other comments are? Yes, please.
That's one. The second, my concern is regarding patients with various necrosis which they manage the ward with the tube drainage. If they bleed, so rather it's a logistic thing, rather than taking these patients for CT, why can't we just take them to the, for a conventional angio and plan for embolize rather than wasting the time when doing the CT?
Yeah, I'll answer both questions. The first question being whether you will do any endoscopic ultrasound for the biliary tract. As you know, in 90% of patients, in the stools of patients who have had biliary pancreatitis, stones have been isolated. But as you know, in pancreatitis, there is ileus. You put in your scope, pump in a lot of air, you will end up with a highly distended abdomen. You will end up with what you call abdominal compartment syndrome. So you don't do it in the initial stage. Early ERCP again is controversial. Only in impacted stones with obstructive jaundice, there is an indication for ERCP in which you do a sphincterotomy and remove the stone. Endoscopic ultrasound, I wouldn't do. I would prefer to do an MRCP because next day I want to do a lap chole. If I do an endoscopic ultrasound, same problem, distension of the gas of the abdomen, laparoscopy becomes that much more difficult. So my preference is for an MRCP.
I think I can just modify his answer. You said whether you are talking about every gallstone pancreatitis. Every gallstone pancreatitis.
Every gallstone pancreatitis.
So mild and moderate.
Can operate at the same setting. So even doing an MRCP might be, because of the fluid collections, it may be very disturbing. The MRCP may not be good.
The mild pancreatitis, there won't be collection.
There will be
And
collections.
you have to see the liver function test. You have to see the ultrasound. And if you are going to do it, usually MRCP without evidence, without history of jaundice, without the history of any type of biliary dilatation, or liver function being normal, usually is not
Required. It's not recommended.
yeah.
Yes.
Recommended is only when there is a jaundice, when you are having some strong suspicion, then only it is required. So evaluation, US can be done delayed. When you are doing a mild this thing, delayed only when there is a history of obstructive jaundice or you are suspecting strong suspicion based on the liver function test. So that would be one. Second, your question that you are going for CT angio, in our institute, nobody will do direct angiography. So CT angio doesn't take much time. You have to wheel the patient, see, because for them also it becomes a good way of targeting the vessel. So it is always recommended CT angio if you are very strongly suspect. Once we have knocked off the splenic artery, because there was no aneurysm, but cavity bleed was there. So we said cavity bleed is only from the splenic artery. So I asked our friends to just knock off the splenic artery. So these are the certain ways. May not be have a 100% black and white guideline, but here are the people. In PGI at least, people will not do straight away.
It will be based on a clinical scenario as such.
Yeah.
How rapid and massive the bleed is, and what is the quantity of bleed, and then as he said, all radiologists don't believe in upfront conventional angio and embolization. They would like to have a roadmap before.
There's another reason. Is it a vascular erosion or a venous erosion, whether it's arterial or venous, that you will confirm that there is a bleed first from the CT angio. Second thing is, if you have colonic erosion, you get bleeds from the coronic eroded wall. So you can't be sure whether it's just a colonic erosion or it's a pseudoaneurysm. That's why we get a CT. If there is a leak, the chance of an angiography succeeding is higher. And if there is a bleed and you don't find any abnormality in the arterial vessels in the form of a dilatation or an obliteration of the vessel, you have to look for venous bleeds. And that will be triggered only by finding positive evidence of a bleed in the absence of an abnormal artery.
Another reason why radiologists don't do a DSA directly is that you will require a lot of contrast if you are hunting, you are doing DSA without a roadmap.
Yes.
So if you have a CT angio showing a splenic arterial aneurysm, they'll just put in the contrast into that. It will be a limited study and DSA is not going to take much time. DSA again is an invasive procedure. You don't want to spend too much time. If you are going without any roadmap, you will calculate the celiac first, you don't find anything, then you calculate the SLA. So your DSA is going to be much more complicated. So you have to understand from the point of radiologist also that they want to spend less time on the invasive test.
So, yes.
I have two questions. They are basically for understanding of the excitation and to serve the antibiotic. When the patient with SAP comes in emergency room, as a junior registrar, how should I give the goal direct therapy? Should I give an empirical only, or should I start invasive at the same time? Number one. Number two, regarding use of antibiotic. In this period, how to differentiate with the inflammation from the infection, so I can decide for the antibiotic.
I'll answer your question.
Particular.
The first thing is the duration from the day of pain. If the duration is late, then it's more likely due to infection rather than SARS. And the SARS which is there is because of infection. The second thing is if it's an early inflammation, so patient has presented with abdominal pain and SIRS, do procalcitonin. Procalcitonin does not get raised in inflammation. It gets raised only in infections. So if procalcitonin is more than one, then you go ahead and start antibiotics. That's how you do goal-directed antibiotic therapy in patients with pancreatic disease.
I think correct that it will only increase in.
Yes, I checked just yesterday.
Yeah.
And not only that, it also decides whether your antibiotic is working or not. If there is a
But for pancreatitis, the procalcitonin rule has been deferred now just because procalcitonin is falsely positive in the patient with acute inflammation.
I can give you the reference.
The thing is, procalcitonin has only relevance if it is increasing trend. So procalcitonin single value, if it is 1, it does not have any relevance, it will be inflammatory. Now you have to see, now repeat it after 3 days, repeat it after 5 days. If this procalcitonin for 1, it becomes 2.5. Now it has a very important relevance, there is increasing inflammation. This might indicate a success. But an independent value.
See, the thing is that like CRP is definitely increases in both, but the procalcitonin little bit different and more so, as you said, you monitor it. The important is at what particular time patient had presented. It has been shown in different studies that in first week, usually, until unless there is a colonic perforation ischemia, something mesenteric ischemia, which is another component of acute severe pancreatitis, usually infection doesn't settle. So that's why so many trials have shown. The very nice trials, RCT double-blinded, 2 RCT double-blinded have shown that prophylactic antibiotics is starting. We are talking about it with severe pancreatitis. Starting antibiotics in the first group doesn't help, and it is rather more dangerous. So I think it is important that we should know the timing and then try to include other armamentarium and then decide. So just to summarize, nothing to summary, management of severe acute pancreatitis is a multidisciplinary approach. And as I said, surgery is only in failed PCD or this thing. Sterile necrosis, no antibiotic required. Step-up approach is the first choice. MIS is nowadays performed, have lesser complication than the open. Open necrosectomy still has a role in reoperative surgery. So complications are sometimes life-threatening, and a dedicated team, a good team of the SRs, our junior agents are required to recognize the problem at the earliest point of time and take care of that. Thanks a lot for your kind attention.